John, take us to your scenario when a new patient comes to you. Maybe they've had the diagnosis, maybe they suspect the diagnosis, or you've gotten a report from the pathologist that it's mantle cell. What do you want to see in that pathology report? What are you talking to your pathologist about that you want to make sure that is tested before you go on? And then we'll get to, what is the rest of the workup for a newly diagnosed patient?
Right. I think it's really critically important to make sure you have the right diagnosis. And it's pretty straightforward in this disease. We should be getting molecular testing, and in particular, looking for overexpression of cyclin D1, and FISH testing, looking for the translocation between 11 and 14. Of course, it's pathognomonic for what we would look for a diagnosis of mantle cell lymphoma. And there are rare cases where we may not see that, but certainly that helps us feel very good about understanding the diagnosis and moving forward from that point. And patients have to be staged. They need CT scans, certainly for staging. Most everybody will have advanced stage disease if we look hard enough, and in fact that might be using colonoscopies, because of course about 90% or more patients perhaps will have GI involvement of their disease. Whether they require a colonoscopy or not, I think is controversial. I don't typically do it, but I know others might, maybe even others here on the panel. But it might be even a way of diagnosis that we see sometimes where just on a routine annual colonoscopy or routine colonoscopy, the diagnosis might be made. But the certain important points are the imaging, the FISH studies, and of course confirming the diagnosis through that way and to stage the patient.
So quickly, the typical patient, and we'll just go down the row and then we'll talk a little bit more about how we use risk, but going down the row, do you do a bone marrow with everyone with mantle cell, and do you do a colonoscopy with everyone before and after their first course of therapy?
Well, I do want to know the risk of the patient, but I'm going to assess that risk largely through the MIPI score perhaps, which we'll probably talk about, and understanding the proliferative index of the tumor based on the biopsy. So understanding those things are usually enough to help me know what I want to do. So I don't typically get bone marrows, and I very rarely will get a colonoscopy.
Andre?
The bone marrow biopsy, yes, is important because sometimes we see patients that had been diagnosed and we don't have a FISH panel, and then it allows us in the bone marrow involvement to actually perform a FISH panel and then complete the staging. And then the GI workup, upper and lower endoscopies, is actually positive in over 90% of patients at baseline. So I would recommend to do it at the first restaging to make sure in a patient who's in CR, but I would not do it at baseline.
Good. I tend not to do bone marrow biopsies unless there are cytopenias or concerns about really the cause of the cytopenias. And I would agree if there's still diagnostic workup to do, that can be useful. I tend not to do colonoscopies because I don't think that they're particularly helpful in changing management in asymptomatic patients unless they have something on their imaging finding to suggest. Steve,
I mean, if a patient hasn't had a colonoscopy in 2 years, I generally do it as part of the staging workup. It's my habit to always look at where the disease is before you start treatment, and then go back after you're done your treatment to do your response assessment. And although I have to say, it's not uncommon for the diagnosis to have been made on a surveillance colonoscopy, as John has said. I mean, it's amazing for those of us that do hematologic oncology, the number of patients we see that it was diagnosed by colonoscopy. With regard to bone marrow, I agree with what Andre said. Most of the time we see these patients after a diagnosis has been made, at least at the University of Penn. And so it's nice to be able to get viable cells to do metaphase cytogenetics with some B-cell stimulation, look at complexity of karyotype, and the bone marrow is so frequently positive that if you think it's somebody that you're worried about maybe needing treatment or worried about risk and you want to get more information, I'll do it so that I have viable cells. And you can always fish the formalin-fixed paraffin-embedded tissue, which is fine, and also use that for what I always do next-generation sequencing on that, particularly to look for P53 mutations, because your fish may not show you deletion of P53, but mutation is common, and that really sways my approach to management of patients if their P53 is mutated. So I like to have that information if a treatment decision is going to be made.
Okay, I'm sure we'll come back to P53 in a minute, but Alexey, your practice with regard to bone marrows and endoscopies, and then maybe start to take us into the discussion around the risk profiling of mantle cell patients.
Yeah, typically I would also perform a bone marrow for the reasons that Steve outlined. It typically would be a good source of tissue for molecular studies, as in up to 75% of cases bone marrow would be involved. I do not do staging colonoscopies. I would be actually curious if Steve recommends random biopsies on a colonoscopy.
No, just visual inspection, biopsy suspicious sites. And I, by the way, do upper and lower.
And I think another point is CNS involvement. It's very rare at diagnosis in mantle cell lymphoma. It typically occurs at relapse, 5–10% maybe. So I certainly, unlike in some subsets of diffuse large B-cell lymphoma, I do not perform spinal taps either.